Good evening, everyone, and a very warm welcome to the Community Mental Health Promotion webinar. My name is Elizabeth Lucas, but you are welcome to call me Lizna, and I'll be your host and facilitator this evening. I am a social worker, researcher, and program coordinator at SACAP, and it's a real privilege to hold this space for this important conversation tonight. We are here to explore how we can move beyond traditional, often centralized approaches to mental health and build community-rooted systems of care that are inclusive, empowering, and sustainable. In a country as diverse and complex as ours, community mental health promotion isn't just a good idea. It's essential, and tonight we'll hear from people who are deeply involved in making it happen. We are joined tonight by three incredible panelists, each bringing unique perspectives and valuable experiences. Dr. Thelma Oppelt is a researcher at the University of the Western Cape with a PhD in psychology from Nelson Mandela University. She focuses on community and health psychology and teaches theory and practice of community-based participatory action research at SACAP. Grisel Pretorius is completing her master's in community mental health promotion and is a qualified psychometrist. She has over 9 years experience in community-based mental health and is the project manager at Friends of Falkenberg Trust, partnering with Falkenberg Psychiatric Hospital to support recovery and reduce the revolving door phenomenon. Dr. Thabisa Matia is a senior lecturer at the University of Venda and a TAU fellow. With roots in social work, her research focuses on mental health, HIV and AIDS, and education in rural contexts. So to open this discussion, I'd like to engage all of our panelists, and we'll start with Dr. Thabisa. So in your view, what are the most critical ways in which traditional mental health systems fail to meet the needs of South African communities? Dr. Thabisa?
Thank you, Liz. Good evening, colleagues. Liz, I must first say, our policy, when the country obtained democracy, our policy focused on deinstitutionalization. But unfortunately, this was done without considering what is in the community. So the problem with our mental health systems now, there's lack of access in many aspects. And when we look at the failures of our mental health systems, they're independent aspects or interdependent contributing factors. We talk of lack of access. You cannot do much without mental health care professionals. We lack, there's a very serious lack of healthcare professionals, especially in rural areas. And when we talk of lack of access, we're not only talking physical access of healthcare facilities, we're talking the distance that many people, especially in rural areas, of course, that they have to travel to access these mental health care services. We're looking at the costs associated with all this. It's either there is a bit of these services within a particular area, but then the cost associated with this. If I can take you to rural areas, for instance, these people have to travel very long distances to access these health services. And in most cases, they don't even get to see the psychiatrist or the psychologist. So it's costly to them, because when you look at a mental health care user, especially a person with mental illness, these people cannot travel alone. That means now there must be a family member who accompanies this person. And secondly, we're looking at the issues of stigma. Stigma is very much, there's too much stigma associated with health, with mental illness. And this, unfortunately, keeps people away from accessing services. It also affects them in a way, it prevents them from seeking help. That means for those with mental illness, they remain psychotic for quite a long time. And we're looking at, even when we have infrastructure, when we have facilities, the conditions are very poor. Um, People go to, there are no waiting rooms, for instance. That means during very bad weather conditions, these people are exposed to these bad conditions. And secondly, because of the distance, it increases the risk. We know in our country nowadays the issues of gender-based violence, the issues of crime. Let me just put it as crime. Then these people are at increased risk of being violated, for instance. And besides that, we have an issue of attitude. Those available healthcare professionals have a bad attitude towards people or mental health care users, which really makes it very difficult for these people to want or to seek help from the available facilities. I'll stop there for now. Thank you.
Thank you, Dr. Tabisa. Very insightful, reminds us of being context relevant, working at a grassroots level and being very sensitive. Dr. Thelma, your opinions on the matter?
Thanks, Liz. So, just to add to what Dr. Tabisa said, yes, of course, we have the failings in a more systemic way where the under-resourced spaces and geographical spaces within which people have to access these services exist. But for me, it's a failing of listening. And the failure of listening takes me to this understanding of the excluding of people from the service, and it's the same people that are claimed to be served. And so the principle of nothing about us without us comes to the fore, where it's really about participatory justice, because it's too often ignored in the design and delivery of mental health services. So, in cases where professionals and policymakers speak about communities but not with them, and these interventions are imposed in such a top down, technocratic manner, it's actually completely culturally irrelevant and blind to the lived realities. And so for me, it's really about engaging communities as co-creators of mental health solutions, and whereby a system that tends to look down on people and a system that reinforces these power imbalances can stop mirroring South Africa's inequalities so that people's experiences are medicalized with an understanding of context. And their voices aren't drowned out by expert driven narratives where someone tells you how your life is and becomes an expert on something they've got no actual experience of. Thanks.
That's wonderful. Thank you, Dr. Thelma. So I can definitely hear the elements of empowerment and advocacy, social justice and collaboration coming through there. Grizel, anything you'd like to add to this point?
Of course. Thank you so much for having me this evening. Good evening, colleagues and viewers. It's lovely to be here tonight. My opinion on the matter, I think, thank you. It was briefly covered by Dr. Tabisa, Dr. Thelma here next to me. But I'm also thinking where our mental health system is kind of failing in South Africa is there's been this long-term focus on just the individual, on the diagnosis, on the symptoms. So it's very medicalized, but you know, there are so much more that influences an individual's mental health. We have to look at factors like family, housing, employment opportunities. You know, it needs to look at a more holistic perspective if we really want sustainable care. So just speaking from my own experience, if I think about the hospital, the psychiatric hospital where I work, These patients come in, they make use of the services. They have this amazing treatment, like really intense treatment. You're there, you have a routine, you've got access to professionals. But then what happens when you're discharged? So you are being discharged in like the care of like relatives, your partners, your like friends. So if we continue to exclude these other people that are viewed as non-professionals, which I completely disagree with, we're going to continue this pattern where people are just going to keep ending up back in, psychiatric care, or even just, normal care, mental health resources. We need to include the voices of the people that are sort of in the process, but not really like, I don't know, we don't view them as the experts, but actually they have lived experiences in this. So that's my opinion. We need to start shifting the perspective beyond the individual, especially in the context of South Africa. Thank you.
Thank you so much, Griselle. So thank you to all of our panelists. I think you have really encapsulated what tonight is all about, that it's community mental health at a grassroots level, sustainable practice and change, and also that it's very holistic. And I love the way that it's been summarized, that everything for the community is done with the community and by the community. So moving on based on that topic, Dr. Thabisa, how would you say can community-based models address the gaps in traditional mental health care?
Thank you again, Liz. I like what my two colleagues have said, involving people in the decision-making process is very important. So having these community-based models helps with that. It also fosters community engagement and community participation in whatever has to do with mental health. And it also improves access, because now remember, whatever will be done will be within the community. Then there will be no long distance traveling. There will be no cost associated. And allow me to use this word instead of equality. Let me use equalness. Because now when we have these community-based, when we adopt the community-based models, we're looking at embracing and respecting everyone's view. That makes that separates or that creates that environment where I, as a mental health care user, do not see you as the healthcare professional as someone who has authority over me, but someone who will listen to my experiences, who will respect my experiences. I think Dr. Thelma spoke about culture sensitive. When we have the community-based services, then we improve the cultural sensitivity, because then we get to understand the culture of that particular community, what works and what doesn't work. And the issues of stigma, again, we reduce stigma, because I think one thing that makes people to stigmatize others is lack of knowledge, lack of understanding of these people's experiences of mental health issues. But when we have community-based services, then we increase on education, creating awareness, people getting to know what these people feel, what these people are experiencing. And most importantly, the fact that having a mental health problem now doesn't mean you are less of a human than the other person. And the fact that anyone can experience mental health issues. And the other important thing is that once we work together in the community, then we increase the chances of early identification of mental health problems, and early detection of this. As a result, then it will be easy for people to get assistance or help very early before the problem becomes a big issue that is very difficult to manage. Thank you.
Thank you, Doc. I hear we talk a lot about empowerment, inclusion, and cultural relevance at a community level. So, Dr. Thelma, what would this then look like in a real-world mental health intervention or interventions?
And again, thanks, Liz. These words are thrown around as buzzwords, and it's become so problematic in the sense that we've completely lost true meaning of the words, and it's become semantic hooks and tick boxes in so many ways. And so, to me, it looks like where people are actually involved in designing these programs and these interventions in a way that's been egalitarian in its approach, meaning we didn't design something without asking the communities to participate. We've asked them to engage from start to finish. We've asked them, can you define your problem? Can you help shape the solution? And that kind of co-created solutions are really where we get to co-design with the community, where we're using a community health worker who is from the area, who's based in the area, who hasn't got to get past gatekeepers of certain nature, because people are more likely to trust and open up to those who share some kind of background. In some examples, we can talk about language being shared. And it's not just about getting a translator in and ensuring all our documents are translated, but it's actually experiencing the language and fully immersing yourself in the language without a kind of them and us narrative. And I think for me, seeing this play out in reality beyond the textbook has been so very valuable because, again, we try to say, oh no, it can never happen. Oh no, these people won't understand. And we start speaking about communities in defamatory ways where, besides being culturally irresponsive to the needs, we've started addressing the issues with a, this is good enough. They won't know better. And so it matters how you treat depression without addressing the conditions that caused it. It matters how you treat a mental health program when it's linked to food security projects. And I've seen this play out at an NGO where I was actively involved in Lavender Hill. When you Google Lavender Hill and the persons in your room don't look like Lavender Hill. And so for me, it's about seeing how do we include people, and they aren't just ethical ideals, they aren't just cultural tick boxes, but it's a practical strategy to effectively care for people and shift from doing things, again, like I've said, to the community, but really being grounded in your approach. And that grounding being filled with respect, shared power, and acknowledging local wisdom. I think as a university partner, you often go in as the keeper of knowledge. But when you reach the ground, you see people know better than you. So they can teach you something. And it's really also about creating this co-learning space where we value lived experience as expertise. And we look at people and we say, if your mental illness is rooted in trauma, you stop being a client. You actually be a co-designer in the solution. You become a trainer. You become a facilitator too, because this challenge that you've overcome, you are best positioned to show someone else how to overcome. So I'll pause on that point, and my take home for us really is, let's use words that matter. And when we caption things with empowerment and buzzwords and we throw these terms around loosely, let's add a layer of truth to the meanings we've attached to these words. Thanks.
you so much, Dr. Thelma. I heard a lot of sort of wisdom in what you've shared, from how to sort of mobilize the community and working with respect and dignity. I want to take us back to the mobilization of the community and working with stakeholders. So how can we meaningfully include all stakeholders, such as people with lived experiences in the community, as well as the local leaders, etc., not just as beneficiaries, but like Dr. Thelma has pointed out, as co-creators of the mental health initiatives? Grizel, what would be your take on this?
Oh, cool. Thank you for that question. Also just wanted to say, listening to Dr. Thelma speak, it's been so nice because she used to be a lecturer of mine, and it's just this light bulb moment again, igniting all of like these amazing, passionate opinions. So for me, I think to begin with your question, Liz, there, we need to reimagine how we think about the term expertise. We need to sort of start viewing professional perspectives as alongside our local knowledge, lived experience, cultural values, that come with the community. So whoever you are working with, like they are your experts. You are trying to help these individuals and their environment. And the idea is you want to create something that will be sustainable. You don't actually want to come in, which we often see, not just in psychology, but I mean, in research and academic spaces in general, there's long been this movement where I come in, I work with you guys, I use you for my research, and then I sort of leave. And my skills leave with me. So there's nothing that remains. And I'm just thinking, like an example I can give you was, well, this whole process with my master's, it like was conceptualized during COVID time. So obviously my partner was Falkenberg Hospital, and because of COVID, I didn't really have access to inside of the hospital. It was very carefully controlled. So what that period brought forth was, the family caregivers who were feeling isolated, even more excluded from their loved ones inside the hospital. So we were thinking, okay, I want to develop an intervention that could like assist these individuals that we often refer to as the silent healthcare system, mental health system. So I collaborated with social workers, and initially my own thoughts was thinking, a lot of when I spoke to a few caregivers, things such as stigma came up. But when we were discussing what to create, do you guys want like a psychoeducation workshop, or how do you want this to work? And sort of what was surprising is actually a lot of people already knew, what is depression, what is schizophrenia, what does this look like? So they've actually listened to a lot of talks on this. They have seen a lot of brochures. So they actually wanted their questions to be answered, by them, for other people going through the psychiatric process. So what we ended up doing was we created a manual structured for like to answer their questions, such as how does the referral process work? How do I get my loved one into the hospital? Where can I myself find relevant and helpful resources? How are there support groups available for families of psychiatric patients? And so this allowed for an intervention that, I mean, it's still in use today, and we are still implementing family days and things with co-workers that sort of came over the couple years where this was conceptualized. But the point is, I didn't drive that. My stakeholders drove it. That this is a need. This is what they wanted. So it's important to take a step back and to ask, instead of just thinking, hey, I just want to go forth and do something. I have this great idea. You need to actually go and be with the community that you're trying to help. I think a good way to sort of think about these types of approaches is to say, it's more than inviting people to sit at your table, but you need to include these people in the menu that you are serving. and you're all sort of eating it together. So that's sort of an analogy to keep in mind when we're thinking about community-based approaches. Yeah.
Amazing. Thank you so much, Gazelle. I hear you bringing the theory to life. So sort of talking about the realities and the practicalities of how these ethics and how these values translate in practice. So that then leads me to ask the entire panelists, and we'll start with Dr. Thelma, if you can share a grassroots mental health intervention that you have seen or that you have been involved in that really worked. Alternatively, you can also share one that didn't work. And what did those experiences teach you about working with rather than for the communities? Dr. Thelma?
So Liz, I don't think there's enough time on this panel for me to actually share so many of them. But with broad brushstrokes, if I may choose one, I think often we go into a community and you go and see what's wrong with people, right? So you can ask some of the students, they'll tell you a needs assessment would normally go and do um, the how can I help? What can I do for you? What's wrong with your life? So we worked with women that had been victims of gender-based violence. And of course, as counseling students or supervisors of students who are trained in counseling, you want to go in and provide talk therapy, and you want to have workshops, and you want to do all these exciting things around. So tell me how you feel. Tell me what you've been through. The women were tired, sick and tired of telling their story, repeating the horror that is their life. And we very quickly had to change lanes and start finding out, what do women actually want to do? What do they enjoy? And we found out that there were many retired seamstresses in the group. There were many women that had been artists. There were women that had skills just drawing. And we very quickly found that we could design an intervention which honed in those interests and those skills and distracted women from what they were going through. And instead, they told their story by quilting. And the whole project literally was called Weave, Women Everywhere engaged against violence everywhere. But it was then a weaving together of these stories with a quilt. And they could showcase what they had gone through by telling these stories with a picture. And just as the discarded fragments of fabric became a beautiful masterpiece when united, the women found such strength in coming together every Wednesday to do what was called sewing club, not talk therapy, not sharing what darkness united them, but rather these bright, colorful fabrics. And they quilted, and the quilts led to other ideas around entrepreneurship and creative energy. And so instead of hosting yet another workshop on the patriarchy and how women are disenfranchised and how they don't know how to make ends meet, they could suddenly start remembering that they can sew. They are seamstresses, they are artists, and those quilts brought to life those stories, forgotten, but also the negative stories were showcased in such a beautiful way. It brought healing, and healing that we hadn't imagined. Healing that came from a place from deep within, from forgotten skills, forgotten ideals, forgotten pieces of fabric. And they came together in such a beautiful way. And so I too drew strength from that opportunity where I had to learn how to quilt. Whereas I thought I went in as an expert or keeper of knowledge, I had to then understand how to thread a needle differently, work a sewing machine, rather than bringing all my expertise as a community health worker.
That's beautiful. Thank you so much, Doctor. I think you muted yourself at the very end there, but I think we hear the passion and the buy-in and the community-driven centeredness. I think that is what the magic in the program or in any community based intervention really is. It's that collaborative approach and that learning and sharing amongst stakeholders and community members. Griselle, if you had to choose one example of something that worked or didn't work, what would you highlight?
Okay, so just depending on time, because again, there are so much of this. If I just think about our relationship with the hospital, so I work for Friends of Falkenberg Trust, we're in NPO, and I so wish that other government hospitals had something like us on site, because the idea is we partner with the hospital and we work very closely with sort of service users and family caregivers to fill the gaps. So for example, if I think about quick initiatives here, when a service user is discharged, we send them home with a food parcel, because, you know, a stay in the hospital could be anywhere from 3 weeks to, I don't know, a year. And thinking about, you know, in that time, do you still have a job? How are you going to put food on the table? So we send you home with a food parcel, and we allow you to come back every 2 weeks to get another one. You know, we also provide clothing and all of these things. But what really comes to mind as an excellent initiative that is still running, that we started in 2021, is we've always had a little shop on site. So it runs as a social enterprise. So anything, it's open to the public, and anything you buy there goes right back into our projects, what we do at the hospital. And I remember we were thinking, what could we do? So it was always a given that employ forensic service users in this shop. So everybody who works there are forensic service users. So quickly, very briefly, a forensic service user is someone who was committed a crime, but found not guilty due to reason of insanity. And so they're not fit to rejoin society, but they would be in Friends of Falkenberg for a very long period of time, sometimes even for life. So we were hit with the question of, you know, we've got these service users that live on site. This has become their home. It's been, you know, some 8, 10, 12, 20 years even. And we sort of went to them and we asked them, what would you guys benefit from? You know, we worked with occupational therapists, with psychologists and psychiatrists who worked in that ward, and we also sat with the service users, and all of them said skills development. They want to learn a skill. And so we partnered with Vida eCafe, and we did they sponsored a couple of service users to go on this barista training course. And we have a fully fledged functional barista station, and we employ about 5 forensic service users, and it runs like an internship program. So the idea is that you come and we mimic a real world environment, but all of your customers are very sensitive. You know, they know you're dealing with other service users that come to the shop, other psychologists, occupational therapists, social workers. So there is an understanding. You know, it's a very gentle work environment. But the idea is to actually build up your CV, give you some sort of a skill, and then when eventually, if you form part of the program, to be rehabilitated, or sometimes in some cases they're allowed to have work outside of the hospital. So this prepares you for that. You know, you've got something on your CV, and coffee industry is booming. So it's a great skill to have. It's a good initiative. And also it worked so well and it's so successful because we went straight to the source. What do you guys want to do? And then there's a lot of other ones, but yes, I'm going to cover that because I know there's time, and I really, just want to say that.
Thank you so much, Grizel. That's a wonderful example, and we can again hear the passion, hear the drive, and that's the beauty of community engagement. Dr. Tabisa, similar to the question I've asked both our other panelists, do you have one example that sticks out at the moment that you can share with the group?
Yes, thank you, Liz. I worked closely with home-based care group from a rural area. And this is a group of women who, you know, volunteered to assist people with different social challenges and health challenges. And they're driven by passion. And like Dr. Thelma, I went into the village, you know, wanting to do my research and use these people and leave. But I got to learn a lot about what they do, how they work with people who are not well physically, who are not well mentally, and, help them to be self-reliant. And I must say, one other thing that really impressed me about these home-based care groups, most of the mental health care users that they were working with, living with either their mothers, their grandmothers, their aunts, and already when we talk of women, we're looking at vulnerable populations. So they staying with a psychotic mental health care user increases the risk of vulnerability. But they worked so well with these people that they would teach them that when you wake up in the morning, you must clean your room, you must do this, you must clean the yard, you must do that. As a result, this became a routine for people they were working with. And the other thing that impressed me is that they are the drivers of continuity of care, right? They would remind these people that it's your date to go to the clinic, it's your date to do this and that. And as a result, at the end of the day, these people, the service users were the ones now who will remind the home-based care groups that, look, it's my date, this, will you come with me, or am I going alone and I'll meet you in the clinic? So it really taught me the importance of compassion, that when we are doing things passionately or compassionately and looking, because they are looking at the people they are working with as their equals. So it's very easy for these people to respect them, and they would from time to time get a platform from the community in Bezos where they share with the communities what is about different issues that are happening in the community, about different issues, health issues like HIV and AIDS, like mental health problems. So, and despite all the challenges, because they had challenges, lack of training and everything like that, but despite this, and not getting stipend as promised by the Department of Health, they would still wake up every morning, walk long distances to go and provide support to different people that they work with. Thank you.
Thank you, Dr. Tabisa. Very inspirational. And I think we could, if I speak for everyone, we could listen to the three of you speak about community interventions and the passion you have the whole night. But I know that we have a lot of questions and that our sort of students and our other delegates are eager to engage you. So based on that, I have, I suppose, two more questions, one for you, Dr. Thelma, one for you, Griselle. So if we think about community-led mental health, it requires more than passion, and we know this. It also requires resources and it requires skill. What are the most effective ways you've seen communities build their own mental health ecosystems? And what are the key tools or partnerships that helped? And this question goes to Dr. Thelma.
Thanks, Liz. I know in the South African context, we might be accused of being delusional or sharing some blue skies fantasy planning when we don't talk about resources, and more particularly, how do you fund these initiatives, right? And I think Rizal touched on some of the engagements with sponsorships and so forth. But I think for me, what I found effective has been a community building their health ecosystem by people. And I think we forget what a valuable resource time has become. So, a lot of these successful community led mental health care initiatives requires the concept of volunteerism or volunteership, where someone is willing to say, listen, I'm going to come alongside you and give you my time, not my money. And we know that at SACAP, students do this as part of their training. But beyond that, the key tool and partnership that actually works is the willing heart to do something for someone else when they are not asking you for a fish, but asking you to teach them how to fish. So what we find in community-based settings, like I've said, there's indigenous knowledge, there's tacit knowledge that spans beyond what we know at university. But the things that maybe a student takes for granted, like knowing how to design a spreadsheet or knowing how to schedule an online Zoom meeting, such as this one, becomes such a valuable resource for community members who actually just need to learn how to make linkages with these stakeholders or with these partners. And so sometimes just giving of ourselves and of our time and of our skills that we've taken for granted can really add value to these initiatives. Furthermore, communities have learned to use, like I said, people within the community to then serve or give back. And I think this also goes to more well-known 12 steps programs, where it's self-help programs, but it's also about once you've received this help, once you've understood what a difference doing certain things has done for you, you have this willingness to give back. And that's your last step, where you then want to come alongside others and journey with them. We've also seen great success in mentorship, where young people who maybe can't find an employment within that very community can then be the older brother or older sister for some school-going child. So it's really just about seeing a human being as the treasure that the community holds, and how can that person give of their time, give of their skills to make the other person's lives better. And again, I don't want to use the word Ubuntu lightly, but it's really when I succeed, you succeed. And when I can help you succeed, that is me shining even brighter as a result of your success. Thanks.
Thanks, Dr. Selma. And then as we wrap up, Grizel, what one shift in policy or funding or in mindset do you believe is most urgently needed to support the kind of community-centered mental health work we've discussed here today?
Okay, thank you, Liz. So I think to answer that question, like most deeply for me personally, I feel it needs to be a shift in mindset. Like we need to start changing the way we think about mental health and psychology, and we need to we need to move. It's time, and Dr. Tabisa touched on this earlier when we were chatting. If we look at the history of, well, not just South Africa, but if I focus on South Africa, we had this whole movement, the deinstitutionalization movement. And the idea was that more money and policies would reflect and support community-based initiatives. But, this has not, it's been very slow implementing it. So what we really need to do, we really need to just I think that like even in academia, we need to start shifting away from just treating the symptoms. Mental health is a lot more than that. We need to start thinking about how, how can we improve the mental health of the whole community holistically? So, how are we like wanting to, have somebody recover and stick with their I don't know, their discharge plan and take their medication, if we're sending them back to communities like rough with, I don't know, violence, poverty, if you feel unsafe in your environment, or maybe you don't even have like employment opportunities or way to support yourself or your family, it goes a lot deeper. So we're not actually getting to the roots of the problem by just thinking about it medically. And mental health is closer than we think. Really, it is everywhere, and especially in a place such as South Africa. So I really think, yeah, we need to like move. It needs to become a more holistic approach in how we treat it, how we empower individuals, you know, how if we focus on restoring like dignity and opportunities, we really create a foundation for someone to thrive and to recover. Because, you know, the other idea is also, you know, mental health is sort of this thing that happens to you every now and again, and it's like curable, but that's not always the case. It's management, consistent management. You know, there's no one size fits all. This is going to make you feel better. Like next year, something isn't going to happen and, you know, throw you off course again. So it is consistent management, and it's also like finding the partnerships and like maintaining these partnerships to help someone recover. So definitely a mind shift that needs to change.
Thank you so much, Griselle, and to our panelists. I'd like to hand over to a fourth panelist this evening, Natalie Donaldson, who is our head of postgraduate and professional programs, to give you a brief overview of the Masters of Social Science and Community Mental Health Promotion at SACAP, so what students can expect and how this translates into practice. Natalie, over to you.
Awesome. Thank you so much, Liz. Thank you for giving me the opportunity to talk about our master's program, specifically our Masters of Social Science and Community Mental Health Promotion at SACAP. Anybody who knows me knows that this is probably one of the main programs at SACAP that I'm most passionate about. And just listening to Griselle, Dr. Tabisa, and Dr. Thelma talking about community-based mental health interventions just has made me even more excited about our master's program. So I'm going to try to keep this as brief as possible. But yeah, so the Master of Social Science and Community Mental Health Promotion is SACAP's first master's program, and it was launched in 2019. And I'll say we, but I wasn't even part of SACAP there, but this program has become my kind of baby. I just own it, and I own the thinking behind it. But when we were thinking about what kind of masters do we want to be kind of promoting, and how are we wanting to train future practitioners or professionals in the field of community or mental health, we kind of saw that there was a need for what our panelists have been talking about, which is a more kind of macro community-focused approach to mental health and mental health interventions. And this is not to say that we don't see the importance of the individual focus. That is still important. The space for counseling psychologists, educational psychologists, clinical is very much there. But, you know, as Griselle and Dr. Thelma and Dr. Tabisa have been sort of talking about, mental health challenges are very much linked to kind of social, political, and historical challenges in our country. So systematic inequalities, high trauma, violence, poverty, substance use, all of these kind of things has meant that the kind of individual space is not enough anymore. And we do need more accessible and sustainable community mental health interventions. So what SACAP looked at doing is doing with this master's is we're kind of responding to a growing demand for visionary skilled leaders who are able to design and implement impactful evidence-based mental health interventions at a macro or community-based level, and that are going to bring about meaningful and sustainable change. So our master's program, very briefly, is a 2-year program, and it's offered currently only on our online campus. There's academic modules every term. There's intensive workshops. There's also community placement. So over the 2 years, our students work very closely with the community organization and the communities that organization works with. And then obviously there is a research component. And the aim of the program really is to equip our students with specialized knowledge, practical skills, and community-centered approaches that foster real-world impact through sustainable mental health issues. What excites me most about this program, and I think what makes this master's program so unique, is the community-based participatory nature and approach of the program, not only as a whole, but also in terms of the research component. So throughout the 2 years, students are working very closely with communities, with their community organization, in developing a community-based intervention that addresses, or at least works towards addressing, a challenge that they have identified in working collaboratively and alongside their community to identify. Yeah, so what we've seen so far since the launch of the program is a real difference that our students are making in working with their chosen communities and organizations. But I think most importantly for me is, and what makes this such a powerful program is the shift that we see in students themselves. These are students who thought that psychology could only be done in one way, or mental health interventions and promotion could only be done in one way. And we've seen such a shift in students in their own growth and their own development, but also importantly in how they view mental health and mental health promotion within the context that they're working in. So yeah, just to cut it short, if making sustainable and effective social impact is something that you're as passionate about as I am, then please reach out to us to find out more about our program. I'm even willing to put my email out there if anybody wants to meet and chat about it. Thanks, Liz.
As we wrap up, I just want to sincerely thank each one of our speakers for your grounded, insightful contributions tonight, and all of you for showing up and being part of this space, even in this chilly weather. So tonight's conversation reminded us that mental health promotion is most powerful when it begins within the communities, when it is shaped by local knowledge, supported by meaningful partnerships, and led by people that are most affected. Whether you work in policy, education, advocacy, care, or community leadership, or whether you're just curious and committed, your presence here matters, and your role in this work and this space is valuable. So please do follow us on SACAP's social media channels to stay informed about upcoming webinars, programs, and events, and to access this webinar recording once it's been uploaded. Once again, thank you for joining us. Take care, stay connected, and let's keep working together towards stronger, more supportive communities together. Good night, everyone, and thank you.